That's, that's great. And we're recording it, obviously, like we usually do, so you can pass it off to other persons from your projects or from your hospital. And then also we're going to share it with the Idaho Path to Value program, as well as another couple programs within our center. So Keely is going to post our pre-webinar question, and I'd like everybody to take and answer that. And if we all can remember and try not to jump off until we get this question asked us again for our evaluation purposes. So.
All right, perfect.
Okay.
Thank you.
Thank you all. Well, welcome to our webinar specifically for the Minnesota Path to Value program. I've heard the word community health worker mentioned informally in a number of conversations with each of your programs. And it was one of the requests that you made about 6 months ago for having some additional learning that you wanted to do. And so today, Carl Rush is here with us. And when I hear the name Carl Rush, what comes to mind right away is the builder of the foundation, or the solid rock that the community health worker movement is built on in the United States. When I first began learning more and more about CHWs, Carl's name was always in that conversation. Carl was co-lead on the Community Health Worker Core Consensus Project, C3. So in community health worker circles, you'll hear C3, which really defines the comprehensive roles and skills and qualities of CHWs. The C3 project establishes a national consensus that improves community health workers' practice and policy. I guess I found it to be one of those go-to documents for anybody that is working with community health workers or thinking about having a community health worker program. Carl has been the technical advisor on CDC-funded policy projects, including the author of a policy brief on sustainable financing of community health worker employment. He's the principal author of HRSA's Community Health Worker National Workforce Study, and also a member of CMS's National Technical Expert Panel on Disparities, and subject matter expert for CMS's Innovation Center grantees around community health workers and their learning collaborative. Carl is a founding board member of the National Association of Community Health Workers. And when I think of CDC, HRSA, and CMS, those are all things that we're familiar with and that are really important things in the healthcare that we do. And Carl has been a part of all of those organizations. So you can see how when I think of community health workers, I think of Carl. So I give you Carl.
Great. I was just telling Deb that I keep chasing this whole menu bar around my screen. Where is it now? I got it. Good morning and thanks everybody for joining us. This is a real luxury for me, one that I get to talk about a range of subjects and that a little more time than I often have. I have done a version of some of these presentations in 10 minutes, which is that calls on my Northeastern upbringing far more than where I live now in Texas. We tend to talk a little slower down here. So Deb asked me to cover several different topics, and it's also a luxury to be working with a relatively small group. And so we'll have plenty of, I think, opportunity for discussion since it is such an intimate group. I want to encourage you. I can see all of you on the screen right now. So if there's anything you want to pause and discuss as I'm going through this, we will have time to do that. So please feel free. We can be informal. And Deb, I'd like if we can just go around real quick just so that I can put faces and names and organizations together. That would be great.
All right, get myself unmuted here. Why don't each of you, I'll stack as I see you on my screen, just introduce yourself, the hospital you're from. Carl, how familiar are you with Minnesota?
Fairly. I've worked with
Okay.
folks at the state level there for quite a few years.
So
Yeah.
you can kind of say what part of Minnesota you're from, north, south, east, west, central. We did a little bit of that originally here, but okay, so your name, the
Mhm.
organization that you're from, and what your position is within that organization. And also you could talk about your target population for the project. So we'll start with Jody, we'll move to Anna, and then Brad.
Sure. Good morning. I'm Jody Martin. I'm the marketing and communications team leader for Ely Bloomington Community Hospital. And our target population for our project is working with folks with some mental health needs and looking at a telehealth project. And we are located way up in the northern part of Minnesota, not very far from the Canadian border, right on the edge of the Boundary Waters.
Mhm. Great.
Anna, Brad, and then Julie.
I'm Anna. I'm the Community Health and Wellness Manager at Windham Area Health. So as mentioned before, we're kind of down by that Iowa-Minnesota border. And our target population is the Hispanic individuals within Windham and our surrounding communities down here.
Great.
Maya.
Good to
So
meet you.
Brad Anderson, Vice President of Strategy and Development here at Lakewood. So I oversee the population health work at Lakewood. We are located pretty much in the center of Minnesota, and our population is CHF patients that are on one of our value-based contracts.
Great. Thank you.
And Julie Carey, Clinic Nurse Manager at Central Care Clinic here in Long Prairie. We are located in central Minnesota, and our population is Hispanic diabetics.
Thank
Okay.
you all.
Great. Well, yeah, I appreciate that little background, some diversity there, both in roles and the populations you're looking at. So, as you know, what I was asked to address in the webinar, and it's going to be, we're probably going to jump around a little bit, but talking about integration of community health workers and readiness of the organization to bring them in, and it is it can be challenging depending on how much, obviously, how much past experience you have and so on. But the I can never tell which control my computer is going to respond to here. The next one, the lived experience is an article of faith almost in the community health worker world. Lived experience is so foundational to the definition of the profession and the key to their effectiveness. And we'll go into a little bit why that is so and what that brings you as an organization. This is, as I will talk about later, most of the employment of community health workers is within community-based organizations, and for them, it's a natural to be thinking in these terms. It's a little more of a learning experience for healthcare organizations. So we will delve into that a little bit. And then lastly, everybody wants to know about sustainability, and we can dig a little deeper in terms of what you want to know about it. But we will be talking about the report that Deb mentioned, which we came out, which we published it from the National Association of CHWs last fall. You may have noticed that a lot of folks are talking about community health workers a lot right now. I was listening to the first of a 3-part webinar series from the National Academy of Medicine about changing payment systems to incentivize health-related behavior and general upstream considerations in health. And 2 of the leadoff panel, a strategy person from CMMI, one of the first terms out of her mouth were community health workers as sort of an of course moment. Her topic was accountability for improving outcomes and cost control. And so for one of the first things she brought up was, well, one of the things you can do is invest in community health workers. And the other panelist is head of system transformation for the VA. And they have a position title called Whole Person Partner, which he immediately equated to a community health worker. And it's a big part of their strategy going forward. So it is a hot topic, and you're probably aware of things going on in nearby states. I should add to this list, Wisconsin. There are states where they've either recently approved or the governor's put forward budget amendments to include Medicaid support for community health workers. These little things are cropping up like mushrooms. And there has been a lot of talk about big funding initiatives out of CDC and more recently out of HRSA, with like a 3-week time window to respond to their latest RFP. For her, in the case of HRSA, it's funding to community-based organizations, and a large number of grants, fairly large scale, like $1 million each, for community health community health initiatives. They are widely assumed to include community health workers, but there are a growing number of states that have established credentialing, generally voluntary certification for community health workers as a means to get on the same page in terms of the qualifications that are required for the occupation. In Minnesota, as you I'm sure are aware, there are standards for the training required of community health workers in order to be paid out of Medicaid. It is not necessarily applicable to CHWs that are paid through some other means. And there's a growing number of states that are establishing registries, and these are open to community health workers, whether they're credentialed or not. And so the states are getting involved in this in a fairly big way. But it is not a given that any organization can simply sort of import community health workers into their organization and make it work. There is a deliberate process you need to go through. So let me pause and ask, for each of your organizations, are you employing community health workers now? And how well do you believe, just very briefly in subjective terms, how well do you believe they are integrated into the organization?
This is Julie in Long Prairie. We currently have a pilot community health worker that works at our site 1 day a week. And it's been very beneficial. She can in no way, shape, or form keep up on the need. So we actually are working on approval for a full-time community healthcare worker position, because we see that there is a ginormous need here.
Okay, thank you. Who wants to go next?
This is Jody from Ely Bloomington. We do not have a community health worker at this time for our facility.
Okay.
This is Anna at Wyndham Area Health. We don't have one right now, but it's been talked about for months. And we actually currently have a community health worker internship position open, but we are struggling to fill that. So we will see how it works out for us.
Interesting. Yeah. Okay.
Alicia, maybe you want to talk about this. I know we've talked about it quite a bit at Lakewood and have never quite gotten there.
Yeah, this is Alicia.
Okay.
Sorry I'm late, guys. I oversee the community health work here at Lakewood. Right now we have a community health coordinator role that really oversees our food pharmacy work and our food access initiatives. So more of a sort of specialized or focused area, specifically around food access. We are definitely looking at leaning into developing a CHW role. I think kind of hot on the press is some of the RHC funding that's coming out around a CHW opportunity on increasing vaccine confidence. So I think that additional funding pool might help nudge us along the pathway to actually establishing that role. And again, you know, initially, more than likely, it's going to be within that RHC, you know, identified criteria or funding space for a CHW, but I think will help provide a great framework and infrastructure for leveraging that forward and into the future.
Okay, great, thanks. So I think this first slide on readiness is pretty generic, and you will recognize a lot of the principles. There certainly needs to be a willingness, and one of the things I've seen in a lot of organizations is that there is a curiosity, but a certain level of commitment might be missing, particularly in senior management, where there may be some need and opportunity to help people become a little more familiar with the nature of the work and the potential benefits. So, but I think we are talking about organizational change, and it's more than, you know, introducing any discipline that you haven't employed before. It's going to be a change, but this is a more fundamental change maybe than most of you may be used to. So this is an issue, particularly, as I said, for healthcare. I mentioned earlier that community-based organizations do have more experience in general with community health workers, and I'll talk a little more about sort of the history involved in that, because these workers are themselves kind of community-based. They're community health workers, but the accent is on the word community. That they are not so much healthcare workers as workers in community health, which, as we all know from the World Health Organization definition, is far more than the absence of disease or injury. And some of the changes in organizations can be profound. There have been some anecdotal reports of maybe some early skirmishes with people who are uncomfortable with some aspects of the nature of the work and the style of the work and the background of the people that are hired to do this work. But then on the other end, we end up with tremendous anecdotes of how transformational the presence of these workers can be, and quotes from physicians saying that I can't imagine what I would do without her in most cases, and that she has made me a better physician. And you may imagine some of the reasons why that kind of change can happen. But we're talking about cultural adaptation here. And in comparison to community-based organizations, I think we're all aware that healthcare and medical or health-related professions have their own culture. And one of the obvious features within many healthcare organizations is that they can be very hierarchical, and the hierarchy of authority and power is based on, and this is a generalization, obviously, but it's based on the level of clinical training individuals have. If you think of that as a totem pole, frankly, community health workers belong on that totem pole at all. They're not clinical providers, so it's not the right yardstick for evaluating their abilities or their contributions. So this can be a cultural shift for a lot of organizations. So I don't want to intimidate you with this, but there are a lot of aspects to integration that need to be considered, and some of them are kind of mechanical, but some of them I'd have to say you can ignore them at your peril. I mentioned earlier it's important that, especially with senior management, they have a clear basic understanding and a correct interpretation of what the nature of this profession is. I don't think it's any surprise that there needs to be clarification of roles and boundaries with other personnel. That can be a cause of some conflict if you haven't prepared for that. It will have an effect on movement of patients within the system, how the handoffs take place, how accountability and chains of evidence, to quote the cop shows, how you are handle accountability for results and for understanding of the patient's situation. As for example, in many organizations, the ability of the community health worker to help establish some context for a patient's situation. What is their living situation like? Their access to basic needs, the presence of stressors in their family life, in their home life, et cetera, which can really help the people who are responsible for diagnosis and treatment. Cultural differences. I mentioned there is a medical culture, and there are expectations. One of the ways this shows up, many organizations have a team approach to engaging community health workers. And when you are rounding or doing team huddles around the needs of a particular patient, there are norms in medical culture that if you can't say it in 15 seconds, just shut up. Get the important stuff. Get the important stuff out to the team. Community health workers can be tremendous storytellers, and that can be a real asset in some contexts, but you don't want them going on for 15 minutes about the situation of the patient, right? So that's part of the onboarding, but it should be part of the basic education of the worker. Infrastructure, as with any new personnel, you can't just sort of plop them down in the organization, expect them to do a job. They need a home base, at least a desk. They need access to technology. You need to figure out what their relationship is going to be to EHRs and that sort of thing. It is that can be really crucial. They frequently will be moving around in the community, will need ideally support for local travel in some form, things like that. Okay. Important to establish from early on, how are you going to evaluate what community health workers do and the outcomes that they produce. There's some important work being done on that. If we have time later on, we can talk a little bit about that. Quality assurance. One of the areas of resistance, or at least reservations, I hear from administrators in healthcare is about how can we be sure that this worker, who may be out in the community all the time, that they're giving people correct information, that they're not exceeding their scope of practice, that they are doing a good job. We don't see them a lot of the time. And so there are various ways techniques that we've learned particularly in discussion between supervisor and community health worker about how to assure the quality of their interactions with patients. And that is part of a broader context of proper supervision of community health workers. Can't just anybody do this. You need to know what you're doing if you're supervising community health workers. And we'll talk a little more about this. HR considerations. This is, I guess, a bigger problem in bigger organizations, but there may be some, this is how we've always done it kind of thing in HR. And integrating community health workers may require being a little more adaptable in the HR system. And that involves mainly the recruitment and hiring process. And then, how ready is your organization to change? Do you have a kind of a rigid culture? Is it difficult to get other changes implemented? These are all considerations for the integration process. We are going to be, and I think we're going to be putting into the chat box this document. I pulled together some references for additional review for you all to look at, educating yourselves about some of the topics that are important in integrating community health workers. So I encourage you to make use of those. If you don't have access to them directly, just shoot me an email and I will be happy to share under the table in some cases if they're copyrighted, a copy of these documents. So I just want to pause there. I've been kind of steamrolling through this. We're almost halfway through our time. Any questions come up for you that you want to talk about? Otherwise, I'll just move on. It is valuable. Deb mentioned the C3 project. This has been useful in a lot of contexts, but it really is helpful within organizations as an educational tool. A lot of people have preconceptions about what community health workers might be, or they may not have a clue. And it's helpful to talk about the range of the roles and skills that are involved in this work. This was based on earlier work, and we recognized that the environment was changing. Back then, in the early mid-90s, the proportion of CHWs working in community-based organizations was even higher. And gradually, over the last 20 years or so, the healthcare world has discovered community health workers, kind of the way Columbus discovered America. But they have come to embrace this idea, and we realized it was important to take a contemporary look at what community health workers do and skills that they need. And so we took those original findings and mapped them against the work of 6 states that were kind of on the leading edge in terms of defining these issues for themselves. There was a fair degree of agreement across these sources, if you will. And so we came up with some recommendations for community health worker roles and skills, which we then validated through a national advisory group and state and local networks. In Minnesota, you have a CHW Alliance, which has been very much involved in policy discussions, and their definitions, skill definitions in particular, were one of the sources that we considered in developing the C3 recommendations. And so we've seen that at least 20, probably more, there's some I'm sure I haven't heard about yet, that of states where they used the C3 recommendations as a starting point in developing definitions, training standards, that sort of thing. And I will just flash these real quick. There are plenty of materials available at c3project.org. I commend that to you. But what we started out with was a set of 10 roles. And there is a tool that you can download in the form of a checklist to look at these things. And so most of this stuff is not going to be a surprise to any of you. There is a lot of organizations have, and training programs have been a little bit shortchanging their constituencies in terms of number 5, advocacy. It is very important in the practical application of what community health workers do for them to be an advocate and encourage patients to be their own advocate within the system. And so one of the things that we added, number 10, is their roles in evaluation and research. And we're finding that a lot of folks are learning some more progressive ways of engaging community health workers in their own program evaluation and in research studies. If you're doing a pilot project, for example, how are you going to evaluate that? And what is the role of your community health worker in conducting that evaluation? And should they have a voice in defining how that evaluation is going to be done? The skills, similar, there are a total of 11 skills, and these will not be, again, a surprise, but a lot of times the training of community health workers shortchanges the first 2 of these. I will come back to in a minute why this is important, but the community health worker role is very much based on relationship and trust. And so it's really important to hone the skills of community health workers in establishing and maintaining that communication and trust with patients and with others in the community. And then the rest of this first page, again, not too many sort of surprises here. But we've added some things clearly in terms of, as I mentioned, skills to accommodate roles in evaluation and research. But we've also spent more time on what it means to be a professional as a community health worker. When I was teaching, I developed a curriculum that included, I believe it was a total of 12 hours, maybe 14 hours on legal and ethical issues. You wouldn't think that would necessarily be a big deal, but I'll just give you one example that community health workers need some ethical decision-making skills. In most states, community health workers are subject to mandatory reporting policies. If you understand the role of community health workers properly, that responsibility is fraught with ethical dilemmas. If you report somebody for elder abuse or spousal abuse or other things that are considered to be mandatory reporting categories, they can undermine their ability to function in that community. I'll just let that sink in. So they've got some tough choices to make. They and their supervisor have to figure out ways of handling those situations that do not render them ineffective in the community that they're trying to serve. Okay. So I'll just let that one sink in a little bit. So any thoughts, questions, comments about the roles and skills? I've gone through this real quickly, and obviously you can spend more time on your own, but I see we're well through our hour, and I'm only on the first component of the webinar. We can find some other ways to revisit these issues, I'm sure. So talking about lived experience, the medical field can be very credential happy, and there's a lot of emphasis on formal education. But I really want to spend a few minutes on this because it is so central to why community health workers are effective. Many folks in healthcare are familiar with the phenomenon of the peer support specialist. And this is mainly in behavioral health, but it can be in other areas like HIV/AIDS, where peer supporters are really valuable to the ability of patients to manage their condition. The role and the skill set involved are very similar, but in the case of community health workers, the lived experience that is most relevant is mainly living in conditions of poverty and racism, rather than their experience with a particular health condition. This gives you some unique opportunities, which I'll get into in a second, but it's also hard to sell in healthcare organizations in particular as a qualification. You know, these people have minimal clinical training. How can they possibly be effective? And so they'll buy the idea that a peer support worker has experience with addiction, let's say. That can be valuable. Well, that's within the wheelhouse of clinical folks to accept that as a qualification. The other stuff is not. And so it's important to remember the history of community health workers. They came out of the anti-poverty programs of the 60s, not out of healthcare. And so it was people like Jack Geiger, whom I've had the privilege to meet and talk with. Their concept was changing the institutions that affect communities by engaging the community in the work. And the federally qualified, the health center movement really had much more of an emphasis on the role of community health workers than it currently does. They're coming back to the fold, fortunately, but it is, I think we all recognize we have persistent issues of health equity, and it relates to access, quality of care, outcomes, and of course, certainly social determinants of health generally. So in healthcare, how is this emphasis on lived experience? What do community health workers bring to you because of that? And I think we all recognize, and I've been hearing this on webinars left and right over the last year, our notion of healthcare shifting from a purely transactional system where healthcare institutions are like a vending machine to more relationship-based systems like ACOs. And this means that, and particularly when we're talking about these populations of greatest concern, low income and minoritized populations, that there are challenges for healthcare organizations in establishing that trust and communication. At the most mechanical level, how many times have you heard folks talk about patients who have been lost to follow-up? And if you're an ACO, that's not acceptable. You can't lose people. All right. So that's a really a bottom line issue for healthcare organizations going forward. Secondly, there's been a lot of talk in the last 5-10 years about trauma-informed care, and there's a tremendous benefit in educating providers about offering more trauma-informed care. The point is, with community health workers, they have often experienced the same kinds of trauma as the people that they are trying to help. And there is no substitute for that in achieving empathetic relationship with those patients. Secondly, the lived experience of community health workers includes the fact that they are connected in their community. They know who the gatekeepers are. They know who decision makers are. They know who influencers are within the community. They know where vulnerable people are, which can be a huge asset in disaster response, for example. They have credibility in the community. They are often known before they have a formal title. They are often recognized as natural helpers in their community. And lastly, and I want to emphasize this a lot, their commitment to the work is out of commitment to the community. It's not about having a good job. For most community health workers, this is a vocation or a calling rather than a job. And if you're recruiting people who are mainly looking for a good job, maybe fall somewhere down your priority list. You need to be recruiting people who are really committed to their own community. What this means down the road, and we've seen this especially in team-based care models, is that the community health workers are their experts in social determinants. They are their experts in building a relationship with that patient. What can I do to get them to be more open and honest with me as their physician? Well, here's what you can do. And so they can be a tremendous asset in that sense. So I'm going to give a few examples of how this shows up in the education of community health workers. There's some programs that sort of screen for this lived experience thing by having a prerequisite course. One of the most highly regarded programs in the country is at City College of San Francisco. They have 1 credit prerequisite, which is meant to screen out people who are just looking for a job. It's a little bit like, and I've seen a bunch of wonderful parodies on Saturday Night Live of the Scared Straight programs. You know, if you shadow a community health worker in a tough neighborhood, you'll get an idea. This is not all good intentions and Lady Bountiful kind of work. This can be very gritty. Most good programs have either a practicum or an internship where people have to really be out in the field and see what the work is really like. And most certification programs at state level require work experience. That serves a couple of purposes. One is, can you as an individual, can you get yourself hired as a CHW, not as a medical assistant or a billing clerk or whatever? Can you get a job as a CHW? Can you sell yourself as somebody who knows your community and can move easily within the community? And so there are ways that the training enterprise, and it's important to look critically at the training programs within Minnesota. How well do they do these kinds of things? And how we applied this, I'm going to move a little more quickly here. I'm running out of time. We know roughly at a national level that 80% of community health workers are women of color. And that is just a practical response to the environment. In my own program that I ran here in San Antonio for several years, I looked at the demographics of our students. The median age of community college students in this program was 45. These are not kids coming out of high school. They are people with some miles on their odometer. They are people who have been in the field. They know the realities of their community. And interestingly enough, as you might expect, many of them have been on Medicaid, or the kids have been on Medicaid. And so we had some opportunities in our program. An evaluator, researcher came to me, said, can we get your students to help us design an outreach? I won't go into details. It was not a really sort of primary clinical trial for a drug seeking approval. But the students took this on as an experiential exercise. What's going to work in our community to get women to a degree to be screened? And so there's tremendous learning opportunity in that kind of, again, lived experience. Also, because many of them have been on Medicaid, the state was coming out with new materials that they were sending out to new recipients, new educational materials. And we took that opportunity for the class as an assignment to come up with a critique, which we put into a 3-page letter and addressed it to the state. And they found it very helpful, both the state officials and the students. You know, how are people handling their relationship with Medicaid when they become eligible? Is it confusing to them? What's confusing to them? How can we help them understand? That's all based on experience. And so I'm going to pause here for a second. That's the my sort of dissertation on lived experience. And I'm saying this as somebody who's been doing this stuff for 25 years. There's no substitute for lived experience. If you hire somebody without that lived experience, you may get a very well-intended individual who has received potentially some very good training, but without the lived experience, they may not have their heart in it in the same way that somebody who does have that experience. Any thoughts or questions about that? There are some things that you can do, by the way, and for example, in recruitment and selection, to help you do a better job of locating people who have that it factor, if you will. Okay, you're all just stunned, I'm sure. Okay. So my third subject, which I'm going to have to go through pretty quickly, which is one of my sort of specialty areas, but we have limited time. So first of all, sustainability is not just about financing. I mentioned attending to infrastructure in integrating CHWs and organizational readiness. There is a whole discipline now emerging on trauma-informed supervision for CHWs, and sustainability includes being able to offer that kind of supervision. There are a number of organizations, and I have some of my own business interest involved in supervisor training. It requires an investment in workforce development, maybe even financing their initial training, but ongoing continuing education and paying attention to career advancement, which many employers of CHWs have really not had to confront. You know, if you're only employing somebody on a 2-year grant, there's not much incentive to invest in career development for those workers. And then doing a robust evaluation. There's a wonderful sort of sister project that I've worked with called the Common Indicators Initiative, which are trying to come up with some common methods and metrics for evaluating CHW programs. One of our weaknesses over the years is not being able to compare or pool data across studies because they're not using the same measures. So it's important to do a good job of evaluation, both for internal justification for the program, of course, but also in understanding how to improve it. Sustainable financing in shorthand is a system of paying for community health workers, which does not depend on going back every couple of years for another project grant. And that can either be done by establishing revenue streams such as Medicaid, and there are others, but obviously Medicaid's the big one, or else incorporating the CHWs into your core budget. And I'll give just one example. Starting from about 5 years ago, Penn Medicine, the University of Pennsylvania in Philadelphia, established the CHW program. They are now up to 30 full-time CHWs who are part of the core budget of that health system. They're not dependent on outside dedicated revenue. And that's because their management sees the value to their bottom line and the quality of the care that they're providing to their patients. So CHW financing, and particularly Medicaid, is complicated. In Texas, we call it getting into the tall weeds. You get there very quickly when you look into the stuff. There's been a lot of stuff written, some very good work done on this from very respected organizations. You see Center for Healthcare Strategies and Urban Institute, especially good work that the people that I know at the University of Massachusetts Medical School, they did a groundbreaking study, which is essentially scaling and scoping different scenarios for individual counties in Maine with different health issues, showing what the scale of CHW operations would be required to deliver that issue based on estimated cost and estimated cost savings and actual epi data on that health issue for that county. It was a very, very clever work and much appreciated in the field. Families USA nationally has emerged as a big advocate for Medicaid financing, in particular for community health workers. This is the report that we produced out of NACHW last fall, and that is available online. And I will try and drop that into the chat box before we finish. Some of the principles that we think are very important is keep in mind, even if you are only able to finance a subset of what community health workers do, to recognize and support, work towards payment that supports the full range of what community health workers do. If you are working on population health, you can't settle for an initial financing package that pays for care coordination for people with complex needs. That's not going to cut it in the long run. Avoid medicalizing their roles. We don't want to do that for multiple reasons, including scope of practice considerations, but also to really take advantage of what they're good at. Let's keep them focused on social determinants and relationship development. I worked with a rural health system out of Illinois. You may be familiar with OSF Healthcare. And we talked about some of this stuff about people with complex needs. But it turns out that they and the health plans that they work with were mainly interested in what CHWs could do to engage Medicaid patients in Medicaid and self-pay patients in primary care. Who knew? And so that's where they decided to put their energies. But it is not medicalizing what they do, and encourage you always to engage. And this is mainly aimed at state level work. We talk about this. I mentioned the CHW Alliance in Minnesota. That it's really crucial to make sure that CHWs are front and center in making decisions about how policies that affect them. I'm more or less contractually obligated to bring that up as part of my role with NACHW. It is really, as you can imagine, a core value there. I'll invite you to look at this later on, but this is an example of what I talked about, embracing the full range of roles of what community health workers can do. And ideally, we'd like to have a cadre of community health workers out there who can move fluidly from working on, population health, primary prevention out at this end, as well as working intensively with individuals with complex needs. So there's, it's I think a good tool for thinking about that continuum. Now, in your cases, as health systems or hospitals, that you have a make-buy decision here, and many many healthcare organizations are employing CHWs directly, and it could be, well, there are many of them in community-based organizations already. There is a increasing move to Medicaid health plans, employing or paying for community health workers. Local health departments are a factor in this. And increasingly, you may think about outsourcing to let's say, a local association of CHWs, or to, there's a new phenomenon called social IPAs, modeled on, of course, medical practices, where community health workers band together and contract as a group with the payers, which is an interesting notion. And that is very similar to the notion of a worker-owned co-op. In Nevada, the state recognizes organizations they call CHW pools, which are not healthcare organizations, but can be certified by the state to employ CHWs under contract from healthcare organizations. Very interesting concept. So I'm going to really accelerate here because we're almost out of time. I learned from Minnesota, in fact, I thought that employers really wanted Medicaid, for example, to cover the full cost of a CHW position. But many of them are really just looking to plug a gap. They can come up with support for part of the CHW's time, and they just want a sustainable source to fill that gap. Some of them are on the verge of, or are open to the idea of self-financing for these positions if the evidence is there. And there are folks like NACHW and the CHW Alliance who are only too happy to help you locate the right kind of evidence to motivate that kind of self-financing. And of course, a lot of organizations are at a very early stage. They have no clue in terms of what they would like out of this. I don't think I need to spend much time. Something dropped off of that first line there, where they're most effective. And of course, the environment is changing, but as we in the CHW field refer to the Willie Sutton rule, it's because that's where the money is. And so that's where we're going after it. The payment that you get, Medicaid payment, does not have to follow the same payment methods used for clinical services. That should be apparent, but a lot of times people are not aware of that. This is from the report that we are sharing with you. These are the big options. A lot of this is targeted at people who are looking at a policy level, let's say at the state level, but it is very relevant to individual employers looking at ways that this can be solidified in the long run. What are you as an organization willing to advocate for example, at the state level? And so I'm gonna stop there. While we're talking, I'm going to pull up the and post the link to that report. So we just we're actually at time, and whoever's willing to stay over, I'm willing to stay as long as you would like.
Keely, would you put up the post polling question?
Yeah.
And Carl, I did post it in the chat box for them, so it's already in there. You can post it again to make sure I'm right, but I found it and I stuck it in there. So if you would please take and fill out the our post question, we would really deeply appreciate that. And reflecting on where you mentioned your organization was at with community health workers at the beginning of this webinar, and the material that Carl covered, it just made sense to me, or that I think there's just a lot of takeaways in this particular webinar for your organization with where it's at. And so, Carl, I thank you for putting this information together. But for any of you that have questions, please feel free to just stay on the line and ask them. Carl's a wealth of information, so.
Overwhelmed.
No, I think it was a fantastic presentation. I think, we continue to sort of maybe struggle on the scope of roles. So very early in your presentation, Carl, you talked about roles and boundaries. And I think that's a space where we continue to have some conversation on gathering some consensus across the organization. So I think if you ask providers, they have a certain viewpoint, and you know, care team, support staff, and you know, so it's just really honing in on the scope of the role and then the primary populations that we're trying to reach geographically, based on chronic conditions,
Yeah.
based on SDOH risk factors. So
Yeah. Well, and one sort of minor aspect of what you brought up is that we can think rationally about scope of practice boundaries, and there are clearly things, for example, that nursing personnel may be doing currently that could be offloaded to community health workers that don't require their level of licensure. Some of the things related to routine patient follow-up. And one of the things we've learned is that that issue is a little more subtle because those nurses like doing some of that stuff, even if it doesn't require their clinical expertise. They like that routine interaction with patients. And so they may be overtly objecting, or maybe getting a little passive aggressive about it, but that they they're loath to give up some things that are maybe not the most productive use of their time. And you may have to argue, for example, that in routine follow-up, the CHW may be able to get the patient to be more open and candid about what's going on. You know, the classic situation with medications, where the nurse or physician may say, you know, how are things going with this prescription? And the patient will sort of nod and say, oh yeah, I'm taking it, things, no problem. It's working fine, etc. But they may be more candid with their CHW and say, I couldn't afford to get this filled, or I started taking it and I felt better, so I stopped, or or the side effects were terrible, and they may be afraid to say that to this person in the white coat, because they think that person expects them to say certain things, and they don't want to displease the person in authority. That is, you know, acutely an issue with a lot of low-income patients. And so that's where that follow-up may be something that the nurse enjoys doing, and they may be very good at it in other ways, but that's something that could be outsourced to the CHW very productively.
Other questions?
this might be getting too drilled down micro data, but help me understand what a reasonable panel size would be for a CHW that's doing some of that, more of that direct patient one-on-one, you know, less of sort of the broader based advocacy or policy things, but what sort of is a reasonable on a 1 FTE space?
Yeah, it depends very much on what they're doing. If it is low intensity routine follow-up, they might be able to handle 100 or so at any given time. There is a consideration that you have to work out for yourselves. If it's a grant funded project, there may be a protocol that they can only see them so many times. They may only be able to see the patient so many times. If it's more open, if it's a more intensive relationship, let's say where they're working on coaching on chronic disease self-management or something like that, where they're seeing them more regularly. They're spending time in home visits, which a home visit may last for an hour or two. That the panel may be more like 40 or 50. And so a big variable, as I said, which may be affected by, let's say, grant conditions, is it's not just the dosage. I don't like using that term for what community health workers are doing, but it's not just the dosage, but the duration. Is based on experience, how long do they need to continue to work with a patient? What are the conditions for terminating a relationship with that patient, hopefully for positive reasons. You know, you need to have sort of guidelines that it doesn't go on forever, right? It only goes on beyond a few months under certain conditions. What are those conditions? And then when you find that it's time that the patient is more confident in managing their condition or utilizing the services that they're getting, what is your protocol for ending that relationship in the most positive way? You know, all of those things need to be built into supervision.
Other questions or comments? Well, Carl, thank you for being part of our program today here in Minnesota. Very much so appreciate your resource. And, you know, Carl is very easy to get a hold of and easy to talk to. So as he said, if you have some questions, his contact information is here, and we'll be sending out the slide deck, attaching again the handout with the resources for readiness assessment that he talked about, as well as the recording links you can be taking and sharing these with other members in your community and in your organization, because there might be some community organizations that would be very good partners in working with a community health worker as well. So his contact information will be on that last slide. So with that, I wish everyone a great Memorial Day weekend. Don't want to get ahead of myself here. And I will be talking with all of your programs next week. So thank you for your time.